All right, welcome everybody to our Fireside Chat Friday here at Coronado Psych. I'm so excited today to introduce everybody to Dr. William Taboas. Thank you so much for joining us today. He's a licensed clinical psychologist who works in our practice, and we're just so excited to have him with us today and have him share his specialties with us and his expertise with us. So welcome, Dr. Taboas, to Fireside Chat Friday. I don't know why I chose such a long title for this, but here we are.
Hi, Rika. Thank you for having me.
Yes, of course. So what I want to start off today is just really giving people an opportunity to get to know you a little bit. So tell us, who are you, and what do you do? Tell us about yourself.
I'm William. I am a licensed clinical psychologist, like Dr. Tanaka mentioned. I'm originally from Puerto Rico, so you might hear a little bit of accent here and there. But I actually moved to the United States to pursue a career in psychology. So I went to grad school in New York City. I went to Fordham University. And New York City is a fantastic place to, not just to be a grad student, but also to get training. So I also got training in cognitive behavioral therapy for a number of issues, including anxiety, depression, stress. And I kind of fell by accident into anxiety disorders. I kind of fell in love both intellectually, and also part of it's been rewarding to help people. And I just stuck with it. I ended up moving to San Diego a couple of years back to pursue a postdoctoral research fellowship in anxiety disorders. And while I see people at Coronado Psych, I also still conduct my research over there at San Diego State University.
Awesome. We're so excited to have you on our team as sort of our anxiety disorder specialist, although I know you help people with all sorts of other, challenges as well. But what I want to talk about with you is your specialty in anxiety disorders. What in your mind, given all the research that you've done and all the work that you've done clinically, what sort of stands out to you most in terms of anxiety disorders, and what draws you to working with those clients?
So I'm still surprised, and I'm still learning how anxiety can manifest itself between individuals, how diverse it is. So it's common for people to experience anxiety. I'm pretty sure anyone in our audience will attest to experiencing some worry, some concerns, some fear here and there, and that's totally normal. And then you encounter people who develop it to an extreme, or it becomes so frequent or so impairing in life or work and things like that. But the thing is, anxiety, just like mostly like other psychological conditions, will depend on its situation or its context to kind of give it a little bit of flavor. So us psychologists and other mental health practitioners will use categories as a shorthand to say this is a social anxiety, this is a panic, and this is OCD. But in reality, there is like major overlap, and so that's the biggest surprise to me about how while at the surface things might look similar, they deep down inside, the anxiety comes from the same place, which is being concerned about things that haven't happened yet or that might potentially happen. And that's the thing that keeps surprising me, that each person's unique history will color their anxiety.
Yeah, absolutely. And I love that you sort of your conceptualization or how you think about sort of anxiety disorders as a category and then all the subcategories, because it is often a little bit of a line in the sand. It's kind of where it lands is kind of what we're talking about. That's not necessarily because there's a specific biologically determined difference there that we can say, oh yeah, it goes down this path if it's social anxiety versus this path if it's a specific phobia, whether or not you're afraid of speaking in public or, afraid of snakes. Some of sort of the biological stuff can be very similar, right? In terms of what we're going through. But then obviously sort of the treatment course will look very, very different. Even though that's interesting because even though the fundamental sort of theory behind it is very similar in some of the ways that we treat anxiety, what it looks like can look so different, which I'm sure is kind of fun from a clinical perspective. I don't know.
Yeah, so that's the part of the art of therapy. There's such a thing. So. I think you and I and other people in our practice are trained in the foundations on how to do evidence-based therapies, right? Like cognitive behavioral therapy or exposure therapy. But those need to be tailored. That's the art of therapy. How do you tailor it? How do you enhance it? Because you also want to make sure that you're kind of hitting the right lessons, so to speak. And that's also the fun of it for me, on my side, which is how do I get to learn, number one, the patient, and number two, kind of tailor the therapy to them to make it the most effective.
Absolutely. I know that you mentioned your postdoc work. I'm wondering, is there a particular type of therapy or type of disorder that you focus on in terms of your academic work?
I do. A lot of my work is on, I would split it into two, and I'll be brief and try to not be too technical. But I like to focus a lot on obsessive compulsive disorder. It's the one that kind of got me into anxiety disorders, and specifically the way you treat OCD. The gold standard is exposure and response prevention, key on the second part because it's essential. So we can talk more about that in a second. And the second component that I focus on would be broadly across anxiety disorders. And if you think anxiety less of a yes/no category, you have it or you don't, or more of the spectrum or dimensions of anxiety, I try to look at what are the key parts of our biology mixed in with our experiences that will tip you over to the disorder part, to the anxiety disorder part. And so I look at anything from thinking patterns to even brainwaves is the most recent stuff that I'm looking at, and try to see if brainwaves, number one, can capture behavior, which is a tall order. And so far we can. That's I'm not the only one doing that, but I'm basically just piggybacking on decades of research. And the second thing is what lessons can we learn from that biophysiological research that we can integrate into therapy. Or at least that we can confirm certain things that we thought that that therapy was working on, because those are other assumptions that we make, that we think that therapy is working on certain parts of our biology, but it's hard to kind of confirm that unless you experimentally try to tease that out.
Absolutely. So cool. There's a very nerdy part of my brain that is going off right now. Like the brainwave stuff is so interesting to think about, because I think we've come a long way in our field, but I think so much of it is always kind of wondering, okay, if this is helpful, what about it is helpful? What's the mechanism? What's going on here? And how can we then take that and then further refine or expand or whatever we need to do to meet more of our clients' needs? I think that's super cool stuff that you're working on. I want to sort of go back, because obviously, in our world, I just want to make sure that there's some good info being shared about what would directly impact someone who's looking into therapy for anxiety. You mentioned, so OCD, for those of you who don't know, obsessive compulsive disorder, and then exposure response prevention, ERP, those are the acronyms that you were using there. And I just kind of want to break those things down a little bit, if that makes sense, in terms of, what are these things? What is OCD, and how does ERP help, and what kinds of questions are you asking around that, in terms of, refining it and understanding those processes a bit more? Because I bet there's really cool stuff that you have in terms of the things you've found out so far.
I'd be happy to share. So, obsessive compulsive disorder, OCD, it's essentially, just to clarify, because it's common for non-clinicians, non-psychologists, or non-therapists to kind of toss OCD around, right? So
yes.
So again, not saying if we consider anxiety or if we as dimensional, some people will experience some of it, right? So think of need to be orderly, cleanliness, need things to be in a certain manner. So that's our natural inclination to kind of manage our environment, and we manage our environment to manage our emotions, and because that's the way our biology works. Mm-hmm. So, but once it gets to an extreme, this is when people. So in OCD, it's the thoughts that having the thought of typically an unwanted thought, and then thinking that the unwanted thought might happen, or even bringing about the thought equates that the bad thing will happen. That's where it starts getting a little bit dicier, and then people start creating rituals around that to kind of make themselves feel less anxious in the moment. But the ritualizing actually reinforces it. It makes it actually go on. So, sure. An example would be a common OCD concern is contamination, which is bar none the most common one. And there are other subcategories such as religious obsessions, harming obsessions, where people might think that thinking of harming a loved one equates to it will actually happen.
Right.
So think of, but let me stick to maybe contamination to make it simple, or at least straightforward. So if you're always washing your hands because you fear that you will get germs, and that will lead to disease, your brain never learns that that the overwashing is unnecessary. So and the way that exposure works is you expose yourself to things that are quote unquote dirty in your mind. Mm-hmm. But I want to emphasize that you're not exposing yourself to actual dangers. You're exposing mm-hmm. yourself to what your brain thinks it might be potentially dangerous. Just to put it in non-technical terms, your brain relearns that the thing that was potentially a threat is not a threat. Mm-hmm. But the trick with exposure is that number one, it requires a lot of practice. It requires practicing multiple times with multiple things and in multiple situations. Mm-hmm. And the other key feature, which I want to make sure that our audience is clear, is that we don't do this just for fun and making the person suffer. We want to emphasize that it's meant to be done slowly, but typically in a hierarchy of things, like from maybe mild, moderate to more difficult things, and slowly tackle one item at a time or a couple of items at a time until the person masters overcoming that particular fear. So that's the other thing that people are kind of hesitant about exposure. Am I going to be doing really scary things? And the answer is yes, but we're not going to do it. We're not going to do old school 1950s what they used to be doing, called like flooding.
Yep.
So we do it in a hierarchical way. We do it slowly. We work with you, and
And I think what's interesting with the exposure piece is that, and this kind of gives into sort of my second question, although I do want to give you the opportunity to talk about the response prevention piece as well, just to educate us, but just to give a pause, is that I feel like there's, it's like the thing I was going to move into next is like, well, why do I need to see somebody who specializes in this type of treatment or in my specific type of anxiety disorder or in the things that I'm specifically worried about? And I think the key sometimes with exposure is sometimes people, and I guess you can have success on your own. It's not to say that that's not possible, but sometimes what can happen with exposure is that if you're not really systematic in it, and if you're not really on it in terms of, keeping to whatever schedule you come up with, right? And exposing yourself regularly enough, I feel like that's kind of a tricky area where people can get into trouble because, you could expose yourself and have the emotional response. And then if you don't expose yourself enough, again, soon enough, right, then it actually can reinforce the anxiety. So this is all just to say, it's such an, I feel like it's such a cool sort of and obviously very effective way to treat, but I think it's also so important to make sure that we're working with somebody, or when you're working on your own, even that you're taking the time to make sure that you're going through the process appropriately, because it can potentially backfire if you're kind of winging it. And not doing it super mindfully. So just side note there. I don't know if that makes sense at all, but I think that's sort of what I've seen in some of my work, and I'm sure in your research and whatnot as well. That's something that you can kind of see happening in sort of failed exposures attempts. If that makes sense.
The metaphor would be, if you're taking a new medication, you want someone to monitor the way it's going. You shouldn't be self-medicating, so to speak. So same thing goes to exposure, because you can only there's certain for some people, maybe where the disorder is not severe enough, it might be safe to do what they call self-directed exposure. And there are books for that. There are some recommendations, but once it passes a certain threshold or of either severity or complexity, maybe the situation has many layers, it's best to have a guiding hand, someone that has experience in knowing how to maneuver a client through not just the hierarchy, but also sussing out maybe there's subtle like safety or avoidance behaviors that the client has, for example, that the client might not even be aware of, or might even dismiss. Oh, that's not an issue, but it's actually kind of getting in the way of exposure. Which by the way, I want to emphasize, Rika, you have a good point. The response prevention for OCD is key, which is you're trying to prevent those avoidance behaviors kind of getting in the way of learning the lesson that exposure is trying to give you. So I think if I would say, if your level of distress and anxiety, whichever type of anxiety symptoms you might be experiencing is to a degree that might need a little bit more attention. This is where specialists can give you a little bit more education and the things that you can do, and also make maybe a very helpful guide in tailoring an exposure hierarchy, and even sometimes creating a plan for you to do things in between sessions, which is really important. So we don't only do therapy in sessions. We encourage clients to do things at home, and having basically essentially a coach on your side. Basically, here are the things that you can do. Here are the many creative ways that you can, of the things that you can, of exposure exercises that you could do at home, outside of your home, over social media for people with social anxiety, for example. Is this is where experience helps. Having experience helps.
Absolutely, absolutely. I feel like something I'm very curious to know for you is, you said that one of the more common concerns that people can have, especially when it comes to something like OCD, is contamination. Obviously, in the light of having all of us lived a year or a little bit more in a pandemic state, how do we discern, between when something is, and we've talked about this a little in our conversation so far, there's a spectrum between normal and abnormal, and like, how do we start to discern when something is really problematic and we need to go seek professional help, and when something is just like, hey, we're in a pandemic and that is why our hands are all raw because of all the washing and all the things that we're doing. How do we put those things together, and how do you as a clinician put those things together for clients?
Sure. So it's a great question. So this is something that has come up in every mental health circle. So how to maneuver therapy and assessment and treatment plans in a world of COVID. And this has become very interesting for people that study anxiety. So not just for OCD. So OCD is an easy one to think about contamination concerns, but also think about health anxiety. It used to be known as hypochondriasis. The term today is health anxiety. So health anxiety, people are concerned whether this cough or sniffle is basically, I've been exposed to something. So and people start checking and rechecking online if they might WebMD everything, for example. And instead of getting that reassurance and I'm good, they just go down this hole of doom scrolling, and they just make themselves even more anxious. Another interesting one is social anxiety. So think about how socially awkward the situations are right now. Someone we do.
Well, we're losing a lot of data.
Yeah. So I'll give you a nice one. So like you find someone, let's say at the supermarket, you stumble upon a neighbor and they're wearing their mask the wrong way. Are you supposed to do something, wink, or not say anything? Does it cross your mind? And imagine someone with social anxiety. That's a very difficult situation. Or in some cases, they'd rather not deal with that situation and they just stay home. But that also compounds, and because they're not engaging in any sort of meaningful exercise, for example, getting out of the home, they kind of their social anxiety leads to depressive symptoms. So same thing with people with agoraphobia, for example. All of a sudden, the situation has with the pandemic has compounded on people already suffering from one thing. The pandemic has had major implications or has complicated things. I wouldn't say has made things worse. the interesting part that I've been reading on the data is it doesn't seem like the pandemic has caused more anxiety disorders. The story is more of if you were already prone and would have likely developed the anxiety eventually in your lifetime, the pandemic has kind of triggered that already.
Sure.
So it's kind of it's a stressor that triggered a risk factor, so to speak.
Right.
But yeah, and coming back to OCD, the interesting thing is, since part of the exposure, let's say for contamination, is to get dirty, we're not going to tell patients get COVID. That's like I said before when I was explaining what exposure is. We don't expose clients to actual threats. We expose them to the idea of the threat or a situation that might provoke that sensation. So but the situation itself is not threatening. So so something that we might do, for example, a client might be concerned with, let's say, getting the virus, but still needs to go put gas in the car, still needs to go grocery shopping, but has been chronically avoiding things because of their disability. We would encourage, let's say, them to eventually do something that gets them out of the house if that's their interference. And if the ritual that they engage in is excessive washing, we go by CDC guidelines. Wash your hands 20 seconds, no more, no less. So the International OCD Foundation, for example, or the Association for Behavioral Cognitive Therapy say stick to the guidelines. And not go too much over the 20-second recommendation, as to not reinforce the ritual. So basically, if you're working with those boundaries, you're still doing good exposure response prevention.
Right. Amazing. Well, I guess I'm just so excited to have you as part of our team. Your depth of knowledge around this is just so amazing, and we love having your expertise and picking your brain about all of the fun research that you're doing and all of the great clinical work that you do. And so I really so appreciate you taking the time to join us today for our Fireside Chat Friday. For more information about Dr. Taboas and our practice, feel free to visit our website at www.coronadopsych.com. And thank you so much, Dr. Taboas, for joining us today, okay?
Of course. Thank you.
All right. Bye.
Bye.